Hello, everyone, and welcome. I'm Dr. Sarika Dar, Medical Director at Star Medical, and we are excited to have you with us today for this TropoVisc educational webinar. Thank you for joining us. We are about to dive into autologous visco-supplementation and explore how TropoVisc can truly elevate regenerative treatment in orthopedics. This session is being recorded, and you will receive the full replay after the webinar. And feel free to send your questions anytime in the Q&A box. We will cover as many as we can at the end. So a quick word about our brand. TropoCells is Star Medical's global platform for regenerative orthopedics and sports medicine. TropoVisc is our latest innovation, an autologous visco supplement designed to support sustained regenerative activity when combined with our renowned TropoCells PRP. And now, I'm delighted to introduce our speaker, Dr. Ishay Benedict. Dr. Benedict is the director of the Orthopedic Trauma Service at Brasília Hospital in Ashkelon, medical director at Prolocure Clinic, and one of the leading experts in regenerative orthopedics and autologous biologics. So, Dr. Benedict, the stage is yours.
Thank you, Sari, and good evening, everyone. Thank you for participating in this webinar. I'm very excited to have you all. In the following minutes, I will be able to share with you my experience treating patients with TropoVisc, and please feel free to write any questions you have. We will try to answer as many as we can at the end of this session. So, as an orthopedic surgeon, my experience is clinical, and I will try to make this as clinical oriented as possible. And my patient is Mrs. Smith. She's 67 years old, suffers from diabetes mellitus, hypertension, hypothyroidism, and basically she comes because she suffers long-term pain in her left knee, aggravated by walking, ascending and descending stairs, standing still. She tries any painkiller or non-steroidal drugs that you can think about without any relief of her pain. On examination, she has antalgic gait, swelling of her left knee, varus deformity, and limited range of motion. So as an orthopedic surgeon, I always proceed after that to X-ray. So this is the X-ray of Mrs. Smith. And the diagnosis is quite obvious, osteoarthritis, right, of her left knee. The degree is about 3 out of 4, according to KL classification. So the question is, what's next? How can you help Mrs. Smith at this point that she exhausted all conservative treatment? So as an orthopedic surgeon, the first thing we suggest is intra-articular injections. So the first, this is, as the difference between the osteoarthritic knee and the healthy knee. There's a lot of tissue pathological changes. Some believe that the changes start at the subchondral bone. Some believe that it starts at the chondrocyte, some believe it starts with the soft tissue. Some believe it starts with the muscle. But we will think about it for a second and hold your thoughts for a moment. We will deal with it later on. So, intra-articular steroid injections, the workhorse of an orthopedic surgeon. So I present you a research, 68 patients with knee osteoarthritis divided into 2 groups, match group, 34 each group. One group received injection of corticosteroids. The other group, injections of saline every 3 months for 2 years. The results, no difference between the group regarding disease progression or changes in clinical pain or function. You have the reference of the research. It's a randomized double-blind study. So, but steroids has a lot of side effects. The list is just partial: tissue atrophy, fat necrosis, flushing, depigmentation, tendon rupture, calcifications, flare-ups around the knee, nerve damage, even atrophy of the joint, osteonecrosis, and obviously infection. So I think everybody agrees that steroids is not so a good idea. So maybe hyaluronic acid injection. Another research comparing Journal of Arthroplasty, comparing intra-articular injection of hyaluronic acid to placebo, saline again, in mild and moderate knee osteoarthritis, and another RCT, and the results, although WOMAC scale improved significantly from baseline up to 6 months, hyaluronic acid was not superior to placebo at any follow-up. No subgroup analysis result in superior outcomes. Also, hyaluronic acid is not a good idea. Also, a lot of possible side effects, joint stiffness. This is just partial list: muscle pain, arthralgia, local swelling, redness, bleeding, burning, discolorization, infection, numbness, pain, whatever you want, etc., and more. So let us think a little bit. The next step as an orthopedic surgeon is always treating everything with a knife. So total knee arthroplasty, right? The ultimate solution to any knee arthritis. But actually, I have a lot of things to say about total knee arthroplasty. It's an industry-derived operation, meaning the industry pushes it forward, not the clinicians, not us. It's an ongoing experimental operation. The fact is that every 5 to 10 years, the philosophy changes and the prosthesis always changes. It deals only with biomechanical aspects of the knee joint. And even that doesn't do it so well. Obviously, it damages the soft tissue around the knee because you cut all the soft tissue around the knee. Nobody knows the specific indications. Some surgeons treat KL level 2. Some operate only KL level 4. There is no consensus. And what is some people doesn't operate. Some operations are not doing for diabetic patients, for BMI above 30, etc. There are no indications and contraindication to the operation. There are a lot of side effects, infections, loosening, periprosthetic fractures, and the most important, what is the real satisfactory rate? Nobody knows, because it's really hard to take it under really objective. So let's think for a moment, what causes Mrs. Smith the pain around her knee? So we were taught that it's the cartilage degradation, but actually everybody knows that articular cartilage is not an innervated organ. So maybe the menisci, right? The menisci tear, but we also know that the menisci are not innervated. So what causes the pain around the knee? The only pain receptors around the knee are within the periosteum or inside the joint capsule. So we were taught that joint degeneration causes osteoarthritis. It causes instability of the joint, and instability of the joint causes pain. But maybe it's time to think a little bit different, in a different perspective. Maybe the basic insult is not joint degradation, but it's instability. Maybe the instability causes the problem. Instability and lack of control of the knee causes osteoarthritis, not arthritis, arthrosis. Causes joint degradation, and that causes pain. And I just argue that we need to think a little bit different, because I have a very good proof to my point. We know that some people age with osteoarthritis, meaning just aging of their knees, and some people age with osteoarthritis, meaning inflammatory process within their knees. And nobody knows why some people goes on the first branch and the other go on the second branch. But at least I'm giving you some thoughts to think about. It's really interesting. I'm thinking it's all about mechanical stability of the knee. So if it's mechanical instability of the knee, the solution we need to think about is trying to solve the stability of the knee. And this is where the PRP comes into my world as an orthopedic surgeon. Another very important study comparing intra-articular infiltration of saline, placebo, steroid, hyaluronic acid, and PRP of the knee osteoarthritis. It's also an RCT. It's a very, like the flagship of the interest of me in PRP, because the study concluded that PRP demonstrated the best overall outcome compared to steroids, HA, or placebo for patients with knee osteoarthritis at 3, 6, and 12 months follow-up. And no difference between corticosteroids, hyaluronic acid, and placebo was noticed, meaning PRP is much favorable than any of the above. And another paper comparing effectiveness of intra-articular therapy of osteoarthritis of the knee, a meta-analysis comparing PRP with other treatment modalities. And the conclusion is that PRP offers symptomatic relief, potentially slows the disease progression, and sustain effect up to 12 months. And look at the last sentence, PRP has the potential to influence future knee osteoarthritis treatment guidelines and decision-making. Meaning maybe we're onto something. And actually there's studies comparing different concentrations of PRP. This is how the study are going further now. So the main theme is injecting an otherwise non-pharmacological and non-active irritant solution into the body, generating generally in anatomical proximity to tendons and ligaments, i.e. the joint capsule, in the purpose of strengthening weakened connective tissue and alleviating musculoskeletal pain in that way. And maybe we're just looking at the tip of the iceberg. Maybe we need to think in other aspects, in a new form of way, that we are not asked to address only what we see on examining the patient and on our modalities like ultrasound, CT, X-rays, and MRI, but apply holistic treatment to the whole joint, the organ or the body, in order to restore stability and soft tissue balance, by that getting a longer and better results. Basically, I'm talking about the future that will integrate orthopedic surgery with biomechanics understanding and with biological treatment. it sounds a little bit futuristic, but think about what happened in the field of rheumatology and autoimmune disease. They went from chemotherapy drugs to biological treatment and biological altering disease drugs, and all the field of autoimmune disease has changed in the last 20 years. And if you think about the inflammatory process that occurs inside our body, it influences so many materials, and the cascade is so complex. And thinking that by changing the joint, changing the joint into mechanical joint with surgery, or injecting steroids, you can alter the disease. I think it's a little bit narrow-minded, and we need to think about helping the body healing itself. And this is what the PRP is doing compared to the other drugs. The mechanism of action of PRP is, we don't know much about it, but we know we have some effects that we already know. That injection of irritant solution to tendon and cartilage near bone causes inflammatory response that turns on the healing process by fibroblast proliferation and growth factor production. The ligaments and tendons become thicker, stronger, and contains more fibrous tissue that improves biomechanics and joint function, and by that decreases pain. Hear me out. I never pretend to heal cartilage. I don't think that we are now at the end of 2025. Nobody that I know of knows how to regenerate hyaluronic cartilage. I'm talking only about stabilizing the knee by influencing the soft tissue around the knee. It also inhibits the pathological angiogenesis, which is the basic process of osteoarthritis, because by angiogenesis, new vessel formation, nerve fibers grows, and new nerve fibers grows, and new nerve fibers growing causes more nerve fiber receptors and more pain. And there is a very famous article from Japan that in animal labs, they saw that PRP can actually heal cartilage defects, but this is just an anecdote for you to think about. I don't think we're there with our human patients. Some things works only on animals. And here you can see actual objective results of PRP injection into meniscal tear. You can see an MRI follow-up. The tear is gone. And actually, this is my patient with the cervical myelopathy. I injected PRP around this cervical spine, and you can see here, compared to here, at follow-up, the myelopathy dissolves and clinically improvement of the patient. We inject to the knee according to a map of injection. It's a very standard injection. It's not an intra-articular injection. It's injection to the soft tissue, ligament, and capsule around the knee. And the subject of our webinar is the next level PRP, the TropoVisc. The TropoVisc for me is like a step forward. because instead of dealing with the PRP that is a liquid solution, we do a little manipulation of the PRP. You can see the following video. This is me. We take the PRP, we separate the PPP, the poor plasma poor platelet plasma, and we heat it up, and by that we get restructure its protein into a denser, slower resolving matrix. After we get the matrix, we cool it down and we mix it with the PRP, as you can see me doing here at the video. And we get like a pasta kind of, a paste kind of injection. And it's, we distribute it in small syringes because it's really painful for the patient, because it's it's much more solid than the liquid PRP. And as you can see, it's actually acts as a scaffold. It's an autologic scaffold. The process is very simple. It's only it needs only single centrifugation spin. It's very safe and sterile. It's all inside the closed system. And as an orthopedic surgeon, my most deepest and strong concern is about patient safety and infection. And with working with the closed system, TropoVisc, it's very nice because I think I treated more than I have more than 2,000 patients, something like 10,000 injections up to now, with 0 infections. It's very unique, and I'm working inside the clinic, not inside the operating room. It's and it's available in 2 sizes, 11 ml or 22 ml. I'm using the 22 ml all the time, and it's FDA and CE approved. This is the illustration of the process. And as you can see here, this is another patient of mine with a partial rotator cuff tear. I inject TropoVisc inside the tear, the partial tear, and I can tell you that after about 2 or 3 rounds of TropoCells injection, TropoVisc injection, she changes from a patient that is a candidate for a shoulder arthroscopy for suture of the partial tear, with follow-up ultrasound and follow-up MRIs. The tear were all gone, and now she's without any limitation, no pain. She gained her normal behavior. She exercises every day, and actually I met her the previous week. She is pain-free. And the next example is injection into tendinous. This is the Kerven disease, tendinitis of the first web of extensors. It's a direct injection into the tendon sheet. After also 2 or 3 treatments, the disease is gone. I know a lot of, like the old school inject steroids, but injection of steroid with the proximity to tendons is very dangerous to me. We see from time to time spontaneous ruptures of tendons after steroid injections. It never happens after injection of PRP or TropoVisc. And the last example another patient. She suffers from Ehlers-Danlos syndrome. It's an hypermobility syndrome. She subluxate her costovertebral junction joints, and I inject directly into the joint capsule, and by that I start causing a hyperfibrosis of the capsule, and the instability and subluxation rate of her ribs lowers significantly. By that, I follow her up every very close. So just for the take-home message, actually, TropoVisc is a slow-release tropocells. It's a slow-release version of PRP. The duration of activity is double or more, meaning 2 months compared to 3 to 4 weeks of regular PRP. It's a visco supplement providing natural lubrication, cushioning, and improvement of joint mechanics. It's fully biocompatible. It's no synthetic, no cross-linking, no foreign material reaction. It also delivers mechanical stimulation by restoring viscosity and enhancing load distribution within the joint. It supports biological regeneration through endogenous plasma components, the PRP, and creates a favorable environment for tissue repair. It's a simple, reproducible preparation that every one of you can do in his own clinic. The process is about 30 minutes time, 10 minutes for the centrifuge, 10 minutes for the heating, and another 5 to 10 minutes for cooling down, and you have the raw material for injection. It's applicable across many orthopedic indications. You saw only a few of them: degenerative diseases, acute ruptures of tendons, acute injuries. I use it a lot with very much with a high success rate, and it's very safe. And for patient to ask for another solution than operation, and we prefer autologous and biological solution, it replaces any synthetic solution like steroids or hyaluronic acid. So thank you very much. This is me speaking to you up to now, and now we can open the session for Q&A.
It's always a pleasure to hear your experience, and thank you very much for sharing with us all your what you've been doing in your practice. So now let's go with the question. So we have one here. Is TropoVisc denser than regular PRP? We cannot hear you, doctor. You are muted.
Yeah, sorry. TropoVisc, it's a paste kind of material. It's not liquid as the normal PRP. And according to that, I use a little bigger needle for injection, the blue needle, the 21G. Actually, I use always local anesthetics before injecting either of them, and I use 1 ml syringes in order to avoid the pressure with the injecting the TropoVisc. According to my experience, injecting with high pressure causes the pain. So with 1 ml injections, you get no pressure, and the patient is very tolerable to the injection.
So you do the injection with the 21 gauge syringe needle, sorry, right?
Yeah, 21G, the blue needle.
Thank you. So
Next
we have
question.
some more questions in here. Would you like to address or?
Yeah, I think the next one is for you, Sari, as the chief development of the PRP. It regards the heating of the plastic syringes.
Okay, yes, I see the question. Thank you. So, okay, so the question said, I noticed that PPP is heated in the standard plastic syringe. To what temperature? So the temperature is 100 degrees. Are there any toxic substances released during the heating that could affect what is transferred to the final product? Does the company have any assurances based on published tests in this regard? Okay, so first of all, of course, we have some studies where this has been a process of years and years of research um, to deliver a very safe product. The PPP is being heated in a regular syringe, that's right, from a specific company, the BD company, which we know by now that does not transfer any substances to the final product. We have checked the biocompatibility, the cytotoxicity of this final product after being heated or after heating the syringe. And we know by now that it's completely biocompatible, it's not non-cytotoxic, and we are confident to say that it's completely safe.
Okay, the next question, I actually like it a lot. I could ask it myself. What is the real difference, or how can you choose between injecting high quality hyaluronic acid to TropoVisc? So I want to answer it with a small story. Like more than 20 years ago, when I was a resident, I heard a lecture from a professor of biomaterials in the Weizmann Institution in my country, in Israel. He explores biomaterials, and he took a hyaluronic acid sample. He has a model of a human knee in his lab. He injects the hyaluronic acid into the model, and the model mimics the human walking cycles. And in his lab, it takes samples of the material every few hours or days. And what he found, that AJ dissolves into its basic molecules within something like 15,000 cycles, meaning around a week. So after a week, there is no hyaluronic acid inside the knee. It's just degrades into basic molecules. And we know that TropoVisc stays without the knee. We found traces of TropoVisc inside the knee after 6 months of injection. So if the question is why or when do I use hyaluronic acid, the answer is I don't use hyaluronic acid. I use only TropoVisc injections since TropoVisc was introduced to me. I stopped using hyaluronic acid at all. I'm not using it also in combination with TropoVisc, but I know according to the manufacturer, it's possible. I don't see any gain in that. I hope I answered the question. The next question is, how many ml do I inject inside the tendon? Well, it's really up to the tendon, right? There are tendons like the wrist, the tendons around the wrist, they are very small. I inject even less than 1 ml, half ml. And tendons of the shoulder or I don't know, the quadricep tendons, they can take up to 4 or 5 ml of injection. It's all being controlled and injecting. I inject only under ultrasound, so I have control of what I do in real time. Sorry? The next question for me is how long do I have I used TropoVisc? What is the pain relief comparison to tropo cells for pain relief and the pain relief duration? Well, I don't know how long do I use TropoVisc since it's been introduced. I think I'm one of the first users. The pain relief, I said it during the lecture, it's double the time. If PRP TropoVisc, tropo cells lasts for 3 to 4 months, TropoVisc stays up to 2 months. And the next question, yeah, you can assume that TropoVisc is a visco-supplementation that affects for 2 months. This is the effect that I see in my clinic. It lasts for 2 months, and it's really like standard. All the patients come for follow-up within 2 months, and we do an ultrasound of the organ or the region, and we decide whether to re-inject it. Do I only inject 1 ml of TropoVisc to an injury site? I use 1 ml syringes, but I can inject as many mLs as I want to the same injury site. The usage of 1 ml syringes is only for comfortable for the patient. Next question regarding distribution. Distributing of available TropoVisc, the injection protocol. Well, the injection protocol is the same as for tropo cells. The only difference is the gap between injections. Instead of 3 to 4 weeks, 6 to 8 weeks. This is the only difference. Meaning the patient skips any other treatment. I see potential good indication for treating torn menisci. What do you think? Well, I don't think, I know. I use TropoVisc for torn menisci, and the results are amazing. I also use it for partially tear of ACL, and the results are amazing. Obviously, for complete tear, there's no point, but for partial tear, it's really nice if you can orient yourself within the knee. I inject to the mid substance of the ACL, and for the menisci it's very easy because the tear menisci are basically the periphery of the menisci, so you can, under ultrasound, you can inject directly into the menisci. Next. Does eating the PRP and mixing it with the PPP and mixing it with the PRP acts as an encapsulation of the PRP to slow down metabolization of the PRP for a longer duration healing effect? Maybe Sari, you will answer it regarding the
Yes, of course, I can answer that one. Yes, so the reason why we mix the PRP with the PPP is because the PPP, after the heating process, it's a protein mesh, and in this mesh, when we mix it with the PRP, the platelets get trapped in the mesh, and they are being able to get activated inside this scaffold and release the growth factors for the whole lifespan of those platelets. So yes, it's encapsulation of the PRP to slow down the release of the growth factors, to have it for more time. Yes, that's the question. That's the answer for that question. So the next question is, I missed something. What is the reason of heating the PRP? So we are not hitting the PRP. We are producing a plasma fraction. We are taking the PPP, which does not contain any cells. We are hitting this fraction. Why this is important? Because if we hit cells, we are going to damage them, and then we will have cell debris and cell fragments, and that's a very potent immune trigger. So with the TropoVisc device, we are able to collect the PPP without any cells, heat it to denaturalize the plasmatic proteins, and then we can then take the PRP and mix it when the PPP is already cold or at body temperature. So at this point, we have the mesh of proteins, and we have the PRP that will be mixed with that, and we are not going to damage cells and the platelets, of course.
Sari, the next question is also, I think, for you. It's about research.
So yes, we will be able to share with you studies using the protein heating technique for injection in soft tissues. It talks about, there are some studies on osteoarthritis, and there are some studies on soft tissue showing how the products or heating the proteins and mixing it with the PRP stays in tissue for a certain amount of time with a very high safety profile. So we will be able to share with you if you contact us via email those studies.
All right, the next question is there any situation where I inject tropo cells rather than TropoVisc? So, yes, when dealing with the small joints or small spaces like fingers, I use tropo cells because I think TropoVisc is too irritant for small joints. And also, my protocol is always starts with the first injection of tropo cells. This is for provoking the tissue and because it's much more tolerable for the patient. TropoVisc injections are a little bit more painful and less tolerable for the patient. So first injection is usually, for most of the cases, tropo cells, and from the second treatment, I switch to TropoVisc. The next question is, what about plantar? I guess plantar is plantar tendinitis, right? Plantar tendinitis or Achilles tendinitis, plantar fasciitis. Well, yes, with the capital Y. I use TropoVisc for Achilles tendinitis with much success, and also for plantar fasciitis. It's very, very efficient. Next question, do you only use TropoVisc at your clinic, or do you variate between the two options? I guess two options is tropo cells and TropoVisc. If so, what are the patient's complaints that would make you choose one over the other? Well, I think I answered it. Small joints, I use more tendency the tropo cells because the TropoVisc is a little bit less tolerable and it's irritant. And when I start a session of several injections, I always start with tropo cells as like an initiator for the tissue and provocation of the soft tissue. And then from the second treatment, I switch to TropoVisc. All right. Any other questions? All right, another one, last minute question. Regarding protocol of PRP at first injection and TropoVisc at second, what is the time period between it? Well, as I said, Tropo cells or PRP works for me for 3 to 4 weeks. So I scheduled the second injection, the first TropoVisc, 3 to 4 weeks after the first injection of Tropo cells. All right. Any last minute question? So I thank you very much for your attendance. And I wish you all the best. And thank you for participating with me in this important webinar.
Thank you very much, Dr. Benedict, and thank you all for your attention.